Well, thank you so much for having me. I am happy to be here and happy to be sharing some of my thought processes when it comes to managing this difficult subset of patients, as well as when to think about the use of enterotherapy. So we're going to skip ahead. I'm just going to dive right in to a case. All right, so here we go. This is a real patient of mine, 34-year-old female who had had some worsening GI symptoms over the past several years, most notably nausea, vomiting, early satiety, and postprandial fullness. She also had notable constipation with bowel movements every 2 to 3 days, as well as increased heartburn over the past year or so. She had been eating less, and her family actually was a little concerned about an eating disorder, given a medical history of both depression and anxiety. She also had a notable history of type 1 diabetes, for which she used an insulin pump and had some associated peripheral neuropathy. In the setting of some of these symptoms, she had already undergone a cholecystectomy, and this is now her visit with you after her primary had been just trying her on some antiemetics. So just reviewing again, the cardinal symptoms, what are we looking for when we're even thinking about this? Because patients sometimes don't present to us with gastroparesis, but rather they present to us with symptoms. And the cardinal symptoms that we are looking for in this case are nausea and vomiting, early satiety, abdominal bloating, or abdominal pain. And there can be some additional symptoms, but these are really the hallmark symptoms that we're looking for. In patients with gastroparesis, you definitely see nausea and vomiting the most, about 90% of patients, and 2/3 or so will have abdominal pain. There are a lot of different reasons that people can have gastroparesis. It's not really just a diabetic and idiopathic disease like it was once thought of. And it's important to remember that I'm usually starting right away with thinking about where could these etiologies have come from in my patient population. Obviously, diabetes is still very important here, but we see post-surgical etiologies in about 15% of patients, usually associated with vagal nerve injury. There can be iatrogenic causes, mostly medications here, obviously opiates, but definitely we're seeing it more with these GLP-1 agonists that have become more prevalent. There are, in fact, though, a lot of other medications that you can keep in mind here. And then there's this whole world of idiopathic, kind of this blanket term we've said, other people who have gastroparesis, maybe we're not sure why, but there are probably at least a few subcategories here, post-viral being a really important one. We've seen this for a long time, but it became a lot more highlighted since COVID, when we've seen a post-COVID gastroparesis population as well. Certainly some of these neurologic, autoimmune, and even infiltrative disorders can be etiologies. The big thing to remember here is that a patient presents to you with nausea and vomiting. That differential is exhausting. It is everything that you see here and probably some more. Not just gastrointestinal in nature either, but rather a whole host of things. And so you really are starting with trying to get down and really make sure this is the general area that you're thinking of, or there aren't any overlap diseases. And that can be a challenge in this patient population. And in fact, a lot of patients who present to us with possible gastroparesis end up having something else. And so that's important to keep in mind as well. So going back to our case, and you can kind of click through these quickly just so we highlight it. I wanted to show you some of the things that are important when I was looking at this. So one is that this has been going on for several years at this time. We're talking about some of the cardinal symptoms. We're also talking about some overlap GI symptoms that we see not infrequently: constipation, heartburn. And then there's some concern here for an eating disorder. And it's really important to remember in this population, up to like 3/4 have been screened for things like ARFID, the avoidant resistant food intake disorder. It's not uncommon for them to have altered food behaviors, and it's certainly important to their treatment plan to keep these in mind. Of course, again, reminding ourselves, is a patient with diabetes, insulin dependent, who has depression and anxiety, which can also alter GI specific symptoms. All right, so what is gastroparesis? Again, we kind of laid this out already to some degree. It's cardinal symptoms in the absence of mechanical obstruction, which is most often noted by endoscopy, making sure there's nothing mechanical there. Although you want to keep in mind that the presence of food on endoscopy is not pathognomonic for gastroparesis. Rather, you do need this delayed gastric emptying exam in order to kind of clinch your diagnosis. So keep in mind that delayed emptying and delayed emptying exams aren't really the only measure of gastric function. And in fact, there are other things that if you really wanted a great measure of everything that the stomach can do or is doing, we have a lot of other tests, and in fact, probably not even enough tests in order that can help us here. But in this case, gastric emptying scan is your kind of gold standard. Next slide. The thing to press upon you here is that gastric emptying scans aren't always done properly. So despite the fact that it's the gold standard, getting a really ideal study is not as common as we'd like it to be. When I say ideal, I mean a 4-hour standardized study using solid food. Typically, it's an egg beater meal with some toast and jelly. It has to be off of offending medication. So if your patient is on opiates or GLP-1s or TCAs, they need to be off of those in this testing setting. This should be done as an outpatient. We know that inpatient, especially with the meds they receive or the illnesses that they're dealing with, can have worsened emptying. And so this needs to be done in a standardized outpatient setting. And if the patient is diabetic, a measured blood sugar should be less than 250 prior to this exam. And you can see that this is a really kind of hard subset of ideals and optimization to employ. And we see that all the time. And in fact, we even see that, our standardized testing is only reproducible 70% of the time. That said, again, this is really the gold standard. And our insurance often relies upon us getting this test in order to pursue treatment. So it's important to know that test, but it's also important to understand its potential limitations. All right, so we're going to go back to our case. The diagnosis we've kind of put together now, because what we have is our cardinal symptoms: nausea, vomiting, early satiety, postprandial fullness, in a patient that I think is probably diabetic related, right? She's got an A1C2 of 8.4, which heightens that she might not have the best control diabetes. She had an endoscopy that did not show mechanical obstruction. And then we got this optimized, woohoo, 4-hour gastric emptying scan that showed a 34% residual at 4 hours. So now we've got our diagnosis. So now we got to move on to management. Of course, the more taxing part of this, and trying to figure out how best to treat these patients. We do have some guidance from our GI societies. This is a clinical guideline that was released from the American College of Gastroenterology. And I want to highlight some of the things that really stand out to me about these, and we'll go into them in more depth. The first thing you're going to see on all of these clinical guidelines is really make sure you have the right diagnosis. Given how many things can cause nausea, vomiting, given the potential for iatrogenic causes, given the limitations of our gastric emptying exam, your focus on getting the right diagnosis should be really a strong one. After that, we move through in more of a stepwise fashion, more conservative to more interventional therapies. And that's what you're kind of seeing laid out here, moving from dietary modifications to pharmacologic therapies to interventions. Moving on, the AGA released a best practice clinical practice guideline update. And this was specifically the management of refractory gastroparesis. So what is refractory gastroparesis? The way they defined it here is pursuing both dietary recommendations as well as metoclopramide use for 4 weeks. And persistent symptoms after the use of those two was considered refractory. Now, you can argue what should be considered a little bit refractory versus not, but I think that's a reasonable start because it's kind of all we have that's really FDA approved. Metoclopramide is the only FDA approved medication for gastroparesis, and so that's why they kind of limited it to that. But the big thing in this one that I want to impress is that we take those patients and we really want to separate them out by their predominant symptom. Is this a patient who's coming to you with nausea and vomiting? Or is this a patient who really is kind of erring more on the abdominal pain discomfort side? Again, you're going to see this. Make sure you consider your mimics. Make sure you really have the right diagnosis and you're not forgetting about other things. But then what this one moves through, again, is stepwise from mild, moderate to severe for how to handle each of these symptoms independently. And that mild, moderate, severe is really dependent both on the degree of gastric emptying delay as well as degree of symptoms. So next slide. So we'll come back to that in a second. And what I wanted to do here, though, is just list out kind of the treatment categories and some of the things within them as far as how I think about them. When it comes to diet, we want to talk about something called a small particle diet. And I'm going to get into that more in a little bit, but that's really the diet that we're focused on here. If you can involve a dietitian, if you have one accessible, it can be very helpful as we don't always have the time to go through all the details of that with our patients. But of course, this section also needs to include management of malnutrition if there's need for enteral or parenteral feeding. Oops, sorry, go back. I'm going to go through them real quick. The drugs we'll get through next. Metoclopramide, again, is the only one that's FDA approved, but we'll talk about some of the other antiemetics and prokinetics and newer drugs that might be out there. This one I really want to focus on is that comorbidities and overlap syndromes have to be addressed because they're just so common. So obviously we know about glycemic control. We know that worsened glycemic control can lead to more and more frequent gastroparesis flares, severity of symptoms. Their medication lists always should be at the forefront of your mind when you're looking at these patients. This consideration of functional dyspepsia, John alluded to the study that notes this overlap syndrome here, and considering that in your patients it also kind of alludes to this idea of what is the primary symptom and really kind of considering that as you go. And then I really wanted to put in constipation specifically because we just see that overlap in so many of these patients. And for some, that's enough to incite flares or bring about their symptoms in a kind of heightened fashion. I actually just got a call about a patient of mine who's at a different hospital, and they're like, she's here, but I think her settings and things are okay. I'm like, yeah, but her constipation is really not well controlled. Let's focus on that first. I think that's an important thing to remember. And then finally, we'll talk about the interventions. Of course, they fall into two major categories: gastric electrical stimulation, or the Entera therapy, or pyloric directed therapies, and sometimes we can consider combinations. All right, I'm going to move on. So small particle diet, what does this mean? So we used to say a long time ago, we need to do low fat, low fiber, six small meals a day. And to some degree, that's true. However, well, we want to backtrack that a little bit because telling our patients never to have fiber kind of messes everything up in their system, right? We don't really want to tell them to avoid something so important. But this all comes back to kind of how emptying works in the system. Liquids obviously empty a lot faster than solids. A higher fat content in foods, though, makes solids empty more slowly. So low fat is still definitely preferred. But the idea is, can you make it small? Can you mash it with a fork? And in fact, the small particle diet in this study right here, compared with a control, showed improved symptom scores for nausea, vomiting, fullness, bloating, and some abdominal pain, heartburn, regurgitation. What I mean by this and how I explain it to patients is I do want you to eat fruit, but maybe blend it up into a smoothie. I do want you to eat vegetables. Make your stick blender your friend and make it up into a soup. You can mash it. If you can mash it, you can eat it. Almonds can be ground up into almond flour and used in other forms. That way you're still getting nutrients, but you're getting them in a way that your body can process better. All right, we'll move on then to the prokinetics. Again, like we talked about, metoclopramide is the only FDA-approved one of these medications. The big issue, though, with prokinetics, which I'm sure you guys have all encountered, is side effects and access issues. So obviously, metoclopramide can have some side effects, but one of its bigger issues is the FDA black box warning about the potential for tardive dyskinesia. Now, in more recent trials, this warning and this concern, the risk is considered low. It's actually 0.1% per 1,000 patient years. That said, it can be enough to be concerning for patients. And in fact, you still have to have that conversation because the FDA warning says, use over 12 weeks can be considered a risk. Well, this is a chronic disease, and so use over 12 weeks is almost a given in a lot of these patients. So that's something that we always have to keep in mind, at least have a good conversation with our patient about. Domperidone, another dopamine agonist like metoclopramide, has those same effects, but was taken off the market here in the US because of cardiac dysrhythmias. It is attainable outside of the US, but you have to have an IND in order to prescribe it, and that will also require monitoring on your part with EKGs and serum studies. Erythromycin works in a different way. It's a modal agonist. Primary issue, though, is tachyphylaxis. You just kind of get used to it, stops working. It's also got a slightly restricted supply, so it's a little harder to get, generally speaking, which some of us have noticed on like hospital formularies and such. And then there's prucalopride, which is works in similarly to metoclopramide in that it's a 5-HT4 agonist. Big issue here, though, is that it's approved for constipation, not for gastroparesis, even though it has been shown in some studies to accelerate gastric emptying. But that's something that I will maybe go to if I have a patient who has both constipation and gastroparesis. Moving on, there is, next slide, oh, sorry, potential for a new dopamine agonist to come out in the market. This is just the phase 2b trials for trospiravir. Showed improvement, but we still need a little bit more data to know where this one is going to go. And then there's kind of the other options. So you're seeing at the top, kind of in the yellow, are all the antiemetics that can and have been used in this vein. Then in the orange, you get into a few other types of medications that have at least been studied. Some of these were studied and already taken off as potential options. But short answer is that we're not using any of these commonly, and some may need further study still. And then I put the neuromodulators at the bottom. Sorry, if we could go back for just one sec. I put the neuromodulators at the bottom because while these have been studied for gastroparesis, none of them have been found to be particularly useful. That said, they can be useful in functional dyspepsia, which again, we see some overlap with. So if you go back, you can go forward now, sorry. But if you look again at this clinical practice update, where it really kind of puts out the predominant symptom and leads us down a pathway based on that, you can see that on the right, when you're dealing with abdominal pain, potential for overlap with functional dyspepsia, that's really where you might hit into some of the neuromodulator therapy, things like CBT and hypnotherapy a little bit more. But know that there's a lot of overlap. Next, and then these overlapping disorders really have to be addressed in both of these sides to kind of keep in mind and make sure you're really hitting on the symptoms that the patient's really experiencing. All right, so moving back to our case, remember our primary symptoms were cardinal symptoms, also had this heartburn, constipation, maybe an eating disorder that we should screen for probably. Studies that confirmed our diagnosis. So initially, we started with the smart particle diet. I wanted her to work on glycemic control, got her into her endocrinologist for that. And we did do some screening for the behavioral component and eating disorder side of things in order to address that. We started her on some medications. I used PPI and prucalopride in this case for her constipation because I knew it might help a little bit with her gastric emptying, and gave her promethazine for an antiemetic. And then we went ahead and tried the trial of metoclopramide just to see if we were going to make any real headway there. She came back 6 months later. At this point, she did have her blood sugars under a little bit better control, was kind of following with her endocrinologist as well as with the psychologist at this point. And her bowel symptoms had improved somewhat, but she really just had significant nausea and vomiting, as well as some heartburn despite the PPI. And so at this point, we were thinking about interventional therapy. And the question is here, do we do Entera? So moving on to the interventional therapies for gastroparesis, like I said, they fall under a couple of big categories. There's gastric electrostimulation or the Entera therapy, and then there's the more pyloric directed therapies, things like Botox or surgical or endoscopic myotomy. So starting with Botox, our current guidelines do not recommend routine use of Botox to the pylorus. This is based off of 2 studies, which unfortunately you see here were not large studies, but they were the only randomized control trial that we have. Some will argue that these were plagued by a lot of heterogeneity, which you see a lot in the gastroparesis data. But for right now, it's not recommended that we do Botox routinely. And then there's obviously endoscopic and surgical myotomy. And surgical myotomy has been around, of course, a little bit longer. GPOM's a newer kid on the block in terms of, it's been around since about 2013. And this is one of the studies that is often cited in terms of its success. This is a patient population who got either GPOM or sham, with treatment success seen in the 71%, with improvement in gastric emptying time as well. When you looked at the subgroups a little bit more, the diabetics did better. It was considered more inconclusive in idiopathic and post-surgical populations. There was also a meta-analysis that looked at GPOM over 10 studies. And this one, showed a pooled success rate, probably somewhere closer to the 50 to 60%, is slightly lower than that sham study, but with some adverse events. And I think the thing to remember with myotomy is twofold. One is you may have a loss of response, and that does happen. 2 is to remember that the idea that we focus on the pylorus for emptying doesn't always consider some of the other problems that can be going on in the stomach. When we utilize myotomy in the esophagus, we're not fixing the contractility of the esophagus. We're just utilizing gravity to help things still move forward. It doesn't work as well because we don't have gravity to help to get things through the pylorus here. So if you have things like antral dysmotility or dysrhythmias of the stomach, you may or may not still get the improvement that you're looking for in these cases. So those are just some things to kind of keep in mind when thinking about this type of therapy. Some people ask, well, maybe we should just try and target a little bit better. Should we do something like endoflip of the pylorus in order to help? And right now that's being studied pretty actively. What we know are studies that show there are some lower measures of pyloric distensibility with greater gastric retention, and there can be some improvement of metrics post-myotomy as seen on FLIP. And there might be a role for it pre-Botox. So like actually just utilizing Botox in the patients who have a lower distensibility might help target that a little bit better. What we don't have is really clear normal values for this patient population and good accuracy across providers. There might also be some effects of the sedation because this is an endoscopically performed procedure that we're not fully yet aware of yet. So I think generally speaking, we're trying to gather this data, but we need some larger trials still. All right, so let's move to Entera. Who do we do it for? What's the right population? And these are some of the selection criteria that the company provides to help at least start to guide us. You want to really focus on patients who have been symptomatic for at least a year with well-documented gastroparesis on that 4-hour solid phase nuclear medicine emptying test. It's evidenced by 60% at 2 hours or 10% at 4 hours. These are patients who are considered refractory In this case, they've failed dietary modifications, they've failed your medication trials. And then other than that, they should be just a viable surgical candidate between 18 and 70 years old. That's who this is really approved for. And again, the exclusions really have primarily to do with surgical candidacy. And that's the focus there. In addition, you really kind of want to avoid this in patients who are addicted to narcotics. I often like to tell my patients a little bit too about their patient experience. What are they going to go through here? Coming from the GI side, we can let them know that this is a minimally invasive outpatient procedure, that the stimulator's implanted just under the skin, usually in the periumbilical region. It's connected to leads that are implanted into the stomach wall and are connected. And then the stimulator sends some soft electrical pulses through those leads to the stomach. And it's really just designed to help with nausea and vomiting. The programmer is external, non-invasive, and can be used to adjust levels of what those pulses are doing, or can be used to turn off or on the system if needed. They also want to know a little bit what's going to happen postoperatively. A lot of patients are able to leave either same day or usually within a couple of days. They might have a little site pain for up to 6 weeks, but importantly, they're not having pain from the stimulator. You shouldn't really feel the stimulation. After that, there's some, general advice given about what to avoid, but the big thing they want to know is what to do diet-wise. And oftentimes this is really, keep it conservative for the first several weeks, but then kind of slowly increase as they're able to. And you're really paying close attention to these patients afterwards. Follow-up schedules usually within 1 to 3 months initially, and then can extend out past that. So what I'm doing in these follow-up visits is really utilizing the programmer to check their adjustment, talk to them about their symptoms, what they're experiencing, how much better is it from previous. We kind of utilize this kind of benchmark of, are you 80% better in your nausea? Are you 80% better in your vomiting? And you're aiming for both. You can adjust the settings again in the office and then follow up with them. It might take a little bit of time to fine tune this a bit. But ideally, you get to a point where you can coast for a while. It's important just to note, too, that this is reversible. It can be turned off. It can be removed if needed, and that the device is battery powered. So at some point, the battery may lessen, may need to be changed. That's a lesser procedure than the first implant. And the programmer tells us when that is kind of coming up. So looking at our case, the patient did return 1 in 3 and 6 months, needed some adjustments initially, but by 6 months was doing well, was able to continue on the laxative therapies for her chronic constipation, but ended up being able to wean off the PPI as her nausea and vomiting and such improved. And in fact, because of the fact that she is now eating better, the blood sugar control actually got better as well. So big things that I wanted to just take home, the definition of gastroparesis, cardinal symptoms, plus the absence of mechanical obstruction, and measured delayed gastric emptying. That one's hard to get, but a 4-hour solid phase nuclear study is your gold standard. That said, it doesn't completely encompass the heterogeneity of the disease, of gastric issues. Management typically goes in a stepwise approach, treating your predominant symptoms with diet modifications, and then going towards interventions, all the while paying really close attention to these overlap symptoms and comorbidities. That said, once you're refractory, you can consider these advanced therapy options, of which Entera is one, but really should be part of a multifaceted treatment approach for these patients who have nausea and vomiting and suffering from gastroparesis. Thank you so much.